So my challenge is to discuss the way we're going to change our current treatments with all these new agents that are coming through, and how do we actually prove that what's the most appropriate therapy in a time really where there's a huge number of new treatments, and we've only just touched the top of the iceberg, I think, and Veronique and others will highlight some of the exciting results we're seeing. So this is Leeds last March, so or very near Leeds anyway. So first of all, to acknowledge, I have the pleasure of chairing the UK CLL Trials Group. If this works, for a second. Okay. And just to acknowledge the people involved in our efforts, and I'm sure I've missed out a lot of people on this slide, so I apologise if I have. We've seen some information regarding the new treatments or the standard treatments in CLL, and I'm sure we'll hear more later on, but as you are aware, for patients who are fit enough, and that's obviously an area of active research and discussion, but those who are fit enough for FCR, the standard would be FCR. This is led, of course, initially from the MD Anderson, but then proven without any doubt by the CLL trial from the German CLL study group. This is the latest update that I have of that data, showing a significant improvement in progression-free survival, but as you'll clearly see, the vast majority of patients are continuing to relapse after FCR, although I've not got the data to show you. There's certainly a cohort of patients, probably around a third of patients, who have very prolonged remissions out beyond 10 years, remaining in remission with CLL after FCR. So it's important we don't lose what we've gained with chemoimmunotherapy, because these patients are off treatment, maybe coming to clinic every 6 months. So trying to identify the patients who are going to do well and the patients who are going to do badly with conventional therapies will be key. This was the first trial to show an overall survival benefit for the new intervention, so shown here with a significant, with a hazard ratio of 0.68, so obviously very meaningful clinically. However, if we look at FCR, and this is data from the LUCID trial, and those of you who remember the LUCID trial was an attempt to improve on FCR by adding an anti-CD23 antibody, lumoliximab. This is one of the largest randomized phase 3 trials in relapse disease. The patients entering this study were actually very lightly pretreated, so they'd usually received just chlorambucil or just single-agent pure analog. So these were responsive patients relapsing sometime after single-agent therapy. And what you can see, that the table at the top shows you that the response rates are much inferior to the initial treatment with FCR, and remember, these patients are really not heavily pretreated, with only 15% CRs, 72% overall response. And the median PFS is less than half, despite relatively minor treatment before. And if you look at the bottom left-hand side of the slide, you can see the progression-free survival, which really is very poor. So the reason I put this data up is it shows you that if you achieve a good remission in first response, you have a prolonged remission. But if you treat the patient even with very mild therapy first, and then treat them with the same therapy in second line, you get much inferior responses. So it tells you, I think, that you've got your best chance of getting a patient into a durable remission, and the best chance of curing with a patient, if we're going to move there, is with our first attempt to treat patients, not trying to salvage patients once they've evolved genetic subclones that become resistant to therapy. This is data from our own group that we presented at ASH a few years ago, and I think shows you the same message. So this is data looking at MRD eradication in patients regardless of what therapy they receive. So these are all chemoimmunotherapy, we're excluding allo transplants, so either Campath alone, FCR, FC, etc. And the solid lines show the patients who have MRD eradication with their first remission. So this is overall survival, and if you achieve an MRD negative remission with your first remission out at beyond 10 years, the vast majority, over 90% of patients, are surviving. Whereas if you don't achieve MRD negative remission, so an MRD positive to the red solid line, these patients are significantly worse. If, however, you achieve MRD negative remissions with your second treatment or beyond, which is the hashed line, you can see that the outcomes are much poorer. So again, once you've evolved a resistant subclone, even if you achieve a very deep remission, the outcome is much poorer. So I think the message from those two pieces of information is we should be really optimizing frontline therapy, because that's where we're going to really make an impact for patients going forward. But if you look at the registration trials that are ongoing, this is only a very short and incomplete list. On the top left-hand side of the slide, you can see the registration trials that are being performed in patients who are fit for FCR. So no company can really go into that group of patients because of the success of FCR. What we tend to concentrate on are patients in the top right-hand side who are unfit for FCR, and therefore even with chlorambucil, obinutuzumab, or ofatumumab, the median PFS of 24 months is an acceptable target, and therefore people will go against it, or in patients at the bottom who have relapsed or refractory disease where the outcomes are very poor. So this creates a real challenge for us, because all the drugs that we get approved are going to be in the patients where actually we don't have very effective therapies. And where we do have very effective therapies for some patients like FCR, we don't generate registration quality data. And that's a real challenge, because they're the patients, as I said before, that we need to improve the therapy where we're going to get patients potentially to a curative treatment strategy. So the way registration trials work really is that our current therapies for fit young patients are too effective. We have median PFSs of 5 years. It takes us 3 or 4 years to recruit a trial. So it's going to be at least 7 or 8 years from the initiation of a trial until we prove benefit with our current strategies in terms of endpoints for trials. And that requires a lot of investment and really isn't considered worth doing, because by the time we get there, the field's moved on and the speed of things are moving. So it creates a real challenge for us as to how we're going to improve the treatment for our young fit patients as well as the elderly patients with CLL. What we really need are surrogate markers of outcomes so that we don't have this long wait until we get approval of drugs and the results of trials. And minimal residual disease eradication in CLL over the last 15 or 20 years in multiple modalities has been shown to predict for outcome. And only now are the agencies, the FDA had a meeting 2 years ago, the EMA is actually overtaking the FDA in terms of regulations, discussing whether we can use MRD eradication as a surrogate for licensure of drugs. And this is the second draft of a document produced by the EMA, which the consultation period will finish at the end of June and will undoubtedly become a strategy at which you can get approval of drugs. And this document says that MRD can be used as an intermediate endpoint, so you still have to collect PFS, but the license can be given on the basis of more MRD negative remissions for the new treatment compared to the old treatment. We have the definition of MRD, which is less than 1 in 10,000 cells. One could argue about that because we can do better now, but that's where the data is at the moment. The deeper the remission, the better. We can use MRD flow or allele-specific PCR. We might move on to next generation sequencing as well, but it doesn't really matter as long as the technique is validated. We can screen the blood, but we have to prove it in the marrow. And Emily discussed before, should we change the assessment criteria for CLL? Well, we will do, because we're now 7 years since we wrote the document and the world has changed. And one of the key things is that as the criteria are currently written, you have to stop therapy and measure the response 3 months later, and that clearly isn't appropriate in a world where you're having continuous therapy for a group of patients. And so there are clear things that need to change beyond where we are now. And then we have to report MRD eradication in the marrow as a proportion of all the patients in that treatment arm, not just the ones we assess. Because if we just look at CRs, we're going to see MRD negative rates of 30 or 40%, but that could only be 5% of the whole population. So it's really important we compare like with like and we all report in the same way. So just some data from our MRD. This is from our own group, and the similar data from the German group. Andy Rostron has done a lot of work on this in the UK trials. So blood or marrow, well, this is the data from a large number of FCR patients treated in 2 trials in the UK. And on the left-hand side are the patients who have MRD negativity in the peripheral blood 3 months post-FCR. And what you can see is that about 30% of patients are MRD positive in the marrow when they're negative in the blood. And it's very, very, very unusual to have it the other way around. So you can use MRD in the blood as a indicator of the likelihood of being negative in the marrow, because if you're not negative in the blood, you're not going to be negative in the marrow. But if you are negative in the blood, you need to look at the marrow. And then, as you can see in the middle and the right, these are higher levels of blood involvement, and the colour coding is the clear marrows. So we have to look at the marrows if we're using it as a surrogate endpoint, but actually the blood is still predictive going forward. So these patients who are positive in the marrow and negative in the blood have very low levels of disease in the marrow generally, and take quite some time before they relapse at a clinical level. We probably don't, I'm not put the data in, but we probably don't need to do triphyline biopsies, which I think would be a major step forward, because they really don't add anything to MRD if done appropriately. And if you look at patients who are negative in the marrow at the 3 months beyond the end of treatment, as is shown here, of the 180 patients at the bottom, 6 months post-FCR, 2.4% become positive. By 18 months post-FCR, only 7.2% are positive. If you look at the peripheral blood on the top row, you can see that a greater number become positive because there's an equilibration between the marrow and the peripheral blood. So MRD clearly predicts outcome, and we're using this to model the response to novel therapies. So if we look at a patient who becomes positive, and that's shown here out at about 2 years, as soon as they become positive post any chemoimmunotherapy, not allotransplant, and Peter might show you a bit of data regarding early MRD positive to negativity with graft versus leukemia, but outside the transplant setting, patients inevitably continue to relapse over a period of time before they become positive at a clinical level. And we can use this these are real patients when they first become positive, and you can see that every patient relapses. And actually we can almost use this sort of modelling to predict the level of disease at the end of therapy, which is the level of disease at which you have to get below to get a durable remission. And we're looking at this for the novel treatments. So we might be able to use it to define therapy. And one of the key questions for MRD is where does it fit in the new world with the BTK PI3 kinase inhibitors with AB2199? Well, if we're going to move to stopping these therapies, which I think is really important early on, and we're going to move towards potentially curing CLL, which I think has to be our aspiration, we have to achieve MRD negative remissions. And as we've seen MRD with imatinib in other disease areas, for example, we can use MRD to define the way a patient responds. So, for example, if this is a targeted therapy and the solid would be a B-cell receptor antagonist, maybe the dotted line would be ABT, where you don't see the lymphocytosis. At some point, potentially the patients would become negative. And then what could happen? Well, the patient could continue to become negative and then stop and then be cured. But of course, beyond 3 years, this patient doesn't need the targeted therapy they remain on, because there's no disease that's going to relapse. And we don't, at the moment, know that we're down there. The patient could stabilize and stay the same. And we've got tests which will show us this information. And maybe adding something at this point would eradicate the disease. Or the patient may relapse, in which case we can detect early relapse and look at modifying therapy before the patient has progressed. So it's going to be critical in our trials that we collect the data during the therapy with novel treatments to look at the biology of response and the biology of relapse. So particularly when we start combining small molecules either with chemotherapy or with novel therapies. So in the UK trials, I've shown this data, so I'll quickly go through it, but we've been using oral FCR with GCSF support when necessary, antibiotics, and intense sort of monitoring, if you like. And what we find with FCR, which is the middle column, is that just over 70% of patients achieve a CR or CRI, and of those patients, about 55 to 60% achieve an MRD negative remission in the marrow at 3 months. So we're seeing very high MRD negative remissions, and this is leading to durable progression-free survival. So what are we doing in the UK group in terms of our next generation of trials? Well, the first of the trials which is open is FLAIR, which is for our patients who are fit for FCR-like therapy. This is recruiting 754 patients, either to oral FCR with a 3-month IWCL assessment, or ibrutinib plus rituximab, so trying to take out chemotherapy completely. This ibrutinib will be given for up to 6 years, at least initially. We'll look at the data from other trials. We're assessing peripheral blood MRD every 6 months, and if we see patients who achieve MRD negativity, patients will stop ibrutinib after they've been MRD negative for 6 months in the peripheral blood and in the marrow. It may be that we see relatively few patients who are MRD negative with this strategy, but as I'll show you, we're planning to add other novel therapies to this where we might see more MRD negativity and therefore shorten treatment. So this is a conventionally designed trial with PFS as the endpoint, with the expectation of increasing PFS from 4.5 to 6 years. Just for an update, we have been fairly slow, and I think this is one of the challenges we have now. It's very slow to open trials. Only half the centres are open in 6 months from the start, but despite that, we're ahead of recruitment already. With at the end of February, we should have 42 patients randomised, and we have 56. So it's obviously a popular designer trial for patients and the centres. The other approach, and we're looking at this in the patients unfit for FCR, is not to replace chemotherapy but to add to chemotherapy. And so the Rialto study has now been modified, where patients who are unfit for FCR are randomised to ofatumumab, chlorambucil, or bendamustine ofatumumab, and we have no data really in phase 3 programs for patients having bendamustine in the elderly group, and this is a really important chemotherapy question. And then we'll have an addition of Idela or placebo to both arms, so we can test the addition of idelalisib to chemoimmunotherapy, and patients will receive Idela for 3 years or placebo for 3 years in this trial. So this is almost half recruited now, has been modified since September. And finally, in terms of MRD, we've shown previously that if you use CAMPATH consolidation, and we have a group of patients that we treated several years ago now who remain in remission with MRD eradication with CAMPATH, but that's now not an attractive proposition. So we're now doing the same randomised trial now with obinutuzumab, the antibody that Emily talked about a moment ago, taking MRD positive patients post chemotherapy and randomising them to either obinutuzumab consolidation, not maintenance. This is to eradicate detectable disease in a short period of time versus observation. So that trial is now just opened as well. So that's our frontline portfolio, trying to address put MRD in the context of the novel therapies, and use MRD to guide therapy. But we have a problem, as I alluded to earlier on, that we need to move much more rapidly than we've done in the last few years in terms of phase 3 trials. These are our phase 2 trials over the last 10 years in the UK, which may have changed practice but really haven't fed into the phase 3 programme. They've been slow to initiate, slow to recruit generally, and not linked to phase 3. So we need to look at a much more efficient way of running clinical trials. We have a huge number of drugs or therapies that are effective in CLL, and we're going to have to integrate these either alone or together to achieve prolonged remissions and potentially cure. And I think MRD will be an important endpoint for our clinical trials, but to test all these agents in phase 3 trials is going to be a challenge. If you look at our success, or I should say failure, at doing phase 3 trials over the years, this is the last 15 years of phase 3 trials in CLL. For fit patients, we've done 2 in the UK in 15 years. Even the German group, which is certainly been more efficient over the years, has only been able to do 3, and in fact, as Barbara pointed out, the CLL-13 is going to be pushed out a little bit further, so it won't start till next year. So we're really inefficient at opening trials. Once we've opened, we close them down too quickly. We really need to look at ways of doing phase 3 much more efficiently. And so this is what we need to do, I think, and what we're moving towards. We have a lot of very sensitive techniques to look at how these drugs work, how resistance occurs, what pathways are interrupted by one drug or increased by another. We need to get our phase 2 program to feed into the phase 3 program, and we need to use adaptive trial design, which has become in vogue for some other malignancies. We have a challenge that multiple drugs with multiple companies, and maybe the collaborative groups are the only way we're going to be able to combine these together. And we need to get recruitment so that we can actually address these issues. And we need to have our strategies to be linked together between the international groups. So the other things that are important are biobanking, modelling of response, and look at depth of remission. So we're doing this in 2 ways in the UK. One is with the phase 2 program, which is funded through the LLR, which is the biggest haematology charity in the UK, who have funded an infrastructure for doing trials. And so basically what they've done is funded 13 big phase 2 centres around the UK, shown here. But more importantly, they funded a hub. So on the right side, there's a group of statisticians and trialists who are funded, so we don't have to get additional funding for running a phase 2 trial. So if we get a drug from a company, we can stick it in the program and rapidly get through recruitment. And we've done the first of these trials, the ICICLE study, where we treated 40 patients with either treatment-naive or relapsed refractory CLL with ibrutinib. And what we can do is take a lot of samples off the patients, and it's showing the peripheral blood and marrow hourly and then daily, and biobanking in the red. And we can look at multiple different aspects of the biology of response and resistance. And I really understand how these drugs work at a cellular and molecular level and how resistance occurs. And this has a huge advantage that it's very rapid. So we recruited 40 patients in less than 6 months. We had an abstract in before the last patient was treated, because these are biological endpoints, not even response endpoints. So we can get the data very quickly, and we can use it to inform phase 3. So what we can now do is, because this is a 6-month trial, but the treatments continue, is look at the next trial, which is ICICLE 2, where we add obinutuzumab, and that should open soon, using the same patients and getting more information. Can we get synergy with obinutuzumab? And ICICLE 3 will be ibrutinib plus ABT 199. Again, collect all that information, and we've already planned ICICLE 4 and potentially ICICLE 5. So you can go rapidly through phase 2 trials, gaining biological data. And we're also doing the same with idelalisib, so that this trial will open in the next month, again with idelalisib, which is known as CAL101, so hence the name. So we can use multiple different phase 2 trials to collect information in a similar way and look at what pathways are being hit. And so the key thing then is linking that rapid, efficient phase 2 program to the phase 3 program, and not having to stop and start trials all the time. And that's the use of adaptive trial design. The FDA have been leading the way on this. They've had a few documents in the last 5 years. The latest press release was last month. And the advantage of this type of design is that you can modify trials and go. You don't have to stop a trial all the time. So you have a standard control arm. You have well-powered phase 3 arms that are being added and closed throughout the trial. And you don't stop the trial. You just keep plowing through with new combinations and potentially even changing the standard if appropriate. It's a much more efficient way of doing the trials, rather than doing 3 years recruitment, wait for 3 years for the results, argue for 3 years for the next trial, and then start the next trial. And so we need to use this adaptive type of design to move rapidly through to look at combinations. And so one way we're doing this is potentially modifying FLAIR. So we have ICICLE for relapsed refractory patients at the bottom. When we see a signal that this treatment looks better, to potentially adapt the trial. So now we have 2 phase 3 trials in one, whereas ibrutinib drug X is compared with FCR, ibrutinib R is compared with FCR, and they're both powered independently. Keep rolling through more phase 2 trials until you see another one that's of interest, and then modify the trial so you don't have huge hiatuses in phase 3 trial design, and hopefully rapidly move forward towards cure. So in summary, what we need to do is to look at much more efficient ways of running our phase 3 trials, particularly with all these new agents we have, which are biologically driven. We need to look at, do we replace chemotherapy? Do we add to chemotherapy? What's the duration of treatment? because it may be acceptable to continue indefinitely for a 17p patient, but it almost certainly isn't acceptable to do that for the 3,500 patients diagnosed a year in the UK with CLL. So we have challenges ahead in terms of, for example, resistance emerging and continuous therapy. We need to look at MRD, we need to biobank samples, and we really need to tie in all of the biological data. And then finally, just to acknowledge the huge amount of work that it takes to try and get a program of trials together like this. Thanks for your attention.